All right, welcome back. Let's talk in section 3 here about other medications besides the dopamine blocking drugs, which will be covered in a different module about what we can treat bipolar illness with. So, things that are often referred to as mood stabilizers. So, this is going to be about the anticonvulsant medications. So, it's interesting. Every time an anticonvulsant medication comes out, psychiatry sort of looks to it and says, hey, does that work for bipolar disorder as well? And there are a few that definitely have evidence for them, and I'll talk about them. Those are valproate, carbamazepine, and lamotrigine. So valproic acid, this is a medication with a lot of different names. So divalproix, Depakote, Depakine, valproate, sometimes you see it abbreviated VPA. So this is a drug that has multiple mechanisms of action, largely leaning towards helping with mania. So it has some GABA effects on GABA, so that gives it some sedating effects. It is a protein kinase C inhibitor, so we talked about that second messenger system, which is involvement in mania, and so by inhibiting that process, we may be able to shut down mania. And it also decreases that excitatory sodium inflow with glutamate. So we get less firing of the cells, reduction in overall kind of hyperactivity and mania. And so the data for valproic acid is that it really works better for mania than it does for depression. A lot of people are kept on it after the mania has ended, and we could sort of talk more about that maybe in the discussion section. This is a drug that is often used in hospitals because it is somewhat sedating. It's great for people that are kind of agitated and anxious. It also has better utility for rapid cycling, so people that go through um, three or four, five, six cycles, mood cycles per year. Um, but really it's good on the mania side of things. Starting it again, sort of a hospital-like dosing here, so 250 3 times a day. I sometimes will use an extended release, so like valproate, 500 milligrams. Valproate extended release would be Depakote or divalproix, 500 milligrams once a day at bedtime. And again, we're looking at that 5 day window. 5 days or after, takes 5 days to get to steady state for a therapeutic level somewhere between around 50 to 125 um, on the blood levels. And to get there, you're going to usually need a dose somewhere between like 500 milligrams and 2 grams of valproate. And typically we spread this out. If somebody has GI issues, you can certainly use the extended release, but I often will use just the straight up immediate release capsules. You do sometimes see some of those GI symptoms show up, and that's where the extended release, which are going to be released further down in the gut, are useful. I'd say about 10% of people will get some kind of diarrhea, lower GI stuff on this. The big issue here, whereas with lithium we were looking at the kidneys, we're looking more at the liver with valproate. You can see elevation of LFTs, you can see decrease in platelet levels, and you can occasionally see pancreatitis with this medication, although fortunately I've not seen too much of that. You want to be very careful with this with patients who can bear children. And the reason for that is because there are not many medications in psychiatry that are clearly teratogenic, but this is one of them. It causes neural tube defects, and this is not a medication you want to get pregnant on. And unfortunately, we often don't know people are pregnant until they've been pregnant for 6 or 8 weeks. And so by that time, often the damage is already done. So if you do have a patient who needs to be on this, who can carry children, you want to make sure that they know about the need for robust birth control. And this can also cause polycystic ovary disease in people that have ovaries. And so that is something to bear in mind. So a lot of people will just kind of steer clear of this medication when it comes to people that are of childbearing age and child-carrying age. Your labs with valproic acid are going to be similar to lithium in terms of timing. So again, that 5 day after initiation, you're going to get a valproate level, you're going to get a CBC, so you can start to monitor platelets, and you're going to get LFTs, and you're going to do that again every 6 to 12 months after they've been on the if they're on the medication chronically, and similarly uh, to the lithium, you're going to go ahead and get a level if you're concerned that the level is too high, or if that there's a shift in their mood. If somebody begins having abdominal pain, you're probably going to want to get that worked up, but it might be worth getting an amylase and lipase to look for pancreatitis. Obviously, if you're looking for an ammonia level, your patient's probably already in the hospital, but you should definitely rule out pregnancy before initiating this medication. Carbamazepine is medication we don't use a whole lot of in psychiatry anymore, but it is still available, and it is a reasonably useful anti-manic medication. So this is sometimes abbreviated CBZ, or it's known as Tegretol. Useful if you can't get anything else for mania to work. It's tricky medication to work with because it goes through the CYP3A4, and it can actually induce 3A4. So it's something called autoinduction, where you can actually turn on the enzyme through which it is processed through and end up dropping your levels over time. So typically we do 100 milligrams twice a day to start, and your level is going to be addressed by blood levels. So again, similar 5 days later. And that dose may be anywhere between 600 and 1600 milligrams a day. So here's your meds that it has some challenges with. In the one of the first modules, we talked about how 3A4 induction can reduce the levels of oral contraceptives. So that's a real risk for unintended pregnancy. And this autoinduction problem is really challenging. So this is probably one of the reasons why people tend not to reach for carbamazepine too often, just because it's kind of a pain to work with in terms of drug-drug interactions and monitoring. Similar kind of side effect profile as valproate. These sort of anti-manic, anticonvulsant medications tend to have sort of a sedating effect and can cause some issues around equilibrium and balance. One of the things that is unique to carbamazepine is that we have to keep an eye on sodium. So you can get this sort of this slow incremental hyponatremia that can occur. Now, we know that if we drop somebody's sodium very quickly, your probably sodium level is between 135 and 145 right now. If I were to drop you down to 120 suddenly, you would be totally confused. If we do that gradually over the course of 6 months, you might feel a little off, but you might not notice the sudden change. And the problem with carbamazepine is that that hyponatremia can look like depression, because people will just feel a little sort of aesthetic, a little spacey, a little tired, and you want to keep an eye on that sodium, because if that gets too low, you're going to have some real cognitive effects. So here's your labs. Again, similar framework, 5 days. It's nice, easy to remember. Lithium, valproate, carbamazepine. Labs all happen in 5 days. It's easy to remember. Chunk that information together. You're going to get a carbamazepine level. You're looking for a level somewhere between 4 to 12 milligrams per liter. You're looking for sodium, so go ahead and get that Chem 7. Worth keeping an eye on white cells, because sometimes you see a decrease in white cell counts, and your LFTs. And again, same advice. If you think that the level may be too high, or that the person is showing breakthrough mood symptoms, go ahead and get that level before you make changes to the medication. Make sure they're actually getting enough. And if it looks like a sort of a depressive type episode, make sure their sodium is adequate and hasn't dropped significantly. Now, lamotrigine is a real mainstay of psychiatric practice, and it's a weird drug because it doesn't actually treat mania at all. So it's a lousy drug for mania, and it's not that effective for acute bipolar depression, but it prevents both bipolar depression and reduces mania. So you can think of it as sort of more of like an anti-cycling drug. So you're really a lot of times this gets started when somebody has an acute episode of depression, and then what happens is the depression goes away. But it may not be because of the med. It may be because of just the passage of time, and that depression was going to lift anyways. But a lot of times we'll credit the med. But what we're really doing, if that person stays on that lamotrigine, is that you're going to hopefully forestall the next depressive episode. Because the thing about bipolar disorder, it's not a question of if you will have an episode, it's a question of when. So if we can make that period longer, more time euthymic, then we're doing well. So this works by blocking sodium channels, probably has some impact on glutamate. We talked about that in previous content. Um, and the great thing about it, it's very well tolerated. So this is medication without a lot of side effects. And part of that may be because we do this very gradual titration up, which we'll talk about. So, there was an interest to see if this could be approved for acute depression. The data was pretty inconsistent, and particularly for people with less severe depression, not that effective. The good thing is it didn't cause mania, which is a plus. Didn't seem to make people cycle faster, which makes sense because it's reducing the frequency of those cycles. It does have better antidepressant effects if you combine it with lithium. So lithium plus lamotrigine is a solid combination. And what you're really trying to do is you're trying to make that euthymic period longer. And also trying to reduce the amplitude of those mood episodes. So one of the things I talk to patients about is you're still going to have cycles, but we want them to be fewer and further apart, and we want the severity to be less. So think about this as we're putting down a floor and we're putting down a ceiling. So when you go down, you don't go all the way down into the basement. You stop before you get too far down. And similarly, when you start going up, you don't get up into the stratosphere. You get kind of restrained by this medication effect, which keeps you from going too high. But most importantly, you spend more time feeling well. Lamotrigine, very well tolerated. One of the ways that you can look to see what side effects you should talk to a patient about is taking out the prescribing information and taking a look at this two-column chart. This will be in most contemporary medication prescribing informations, and it gives you a percentage of how many people had these side effects depending on whether they were in the drug group or the placebo group. If the two numbers are roughly equal, you can tell that's something that probably was just going to happen anyways. If there's a one number that sort of stands out higher than the other, then that might be something you want to talk to your patient about. The main things with this, similar to all the anticonvulsants, these kind of neurological sedating effects, maybe some problems with coordination and dizziness. And then there's this question of rash. And we got to talk about the rash, not because we want to scare people, but because we want to make sure that we protect our patients and also protect our liability. There's two types of rashes that happen with lamotrigine. One is known as a benign rash. A lot of drugs can cause benign rashes. About 5 to 10% of people will get some kind of rash on lamotrigine. These are kind of your classic drug rashes. They're blotchy, they don't hurt, you don't feel sick, your labs are normal. Um, and then there's this much more serious rash situation called Stevens-Johnson syndrome. Fortunately, this is very rare. Anywhere between sort of 1 in 5,000 to 1 in 10,000 people on lamotrigine are going to get this, which, is similar to like carbamazepine and valproate. So all of these anticonvulsants can cause the Stevens-Johnson syndrome, but lamotrigine is probably the most well associated with it. Now, Stevens-Johnson syndrome, you're not going to miss it because, I mean, take a look at these folks. They are obviously quite ill. Stevens-Johnson syndrome is serious because you can lose skin. It has to be treated as if it's like in a burn unit because you can get bacterial superinfections on that open skin. But somebody's not going to miss having Stevens-Johnson syndrome because these rashes are painful. They're blistered. You're going to be sick. You're going to have fever. You're going to have leukocytosis. It's going to be in the mouth. The good news is if you haven't had this within 2 months of starting this medication, you're probably never going to get it because most of the rashes happen in the first 2 months. And this really became noted as a problem in the epilepsy literature because when this medication was first rolled out for epilepsy, they were starting with these big doses and people were getting these rashes. So we found that if we slowly introduce the drug, you are much less likely to get one of these rashes. Now, it's important to tell your patients, look, if you go off this medication for more than 5 days, we're going to have to restart this titration again because at that point, 5 half-lives has passed, the medication's left your body. We need to introduce this as if it's a new drug. I also tell patients if you get any rash, stop the medication and call me. And I'll put that on the instructions that are printed up by the pharmacy. I also tell patients, look, don't change your soap, don't change your shampoo, things that might cause you to get a rash. Some people get a reaction to vaccines, for example. So maybe try not to do that at the same time because what you don't want to have is a benign rash that we get nervous about, and then we take the person off lamotrigine, and the lamotrigine maybe could have been really helpful for them. So we just try and make the conditions such that they're less likely to have, kind of a random dermatitis kind of situation. And I'll send people to dermatology and say, hey, can you let me know if this is Stevens-Johnson syndrome? And fortunately, everybody said no that I've had to do that with. It's important to also remember that this is not the only medication that causes Stephen Johnson. Sulfonamide antibiotics are probably the worst offender. And when was the last time we told anybody about Stephen Johnson syndrome before they got a sulfonamide antibiotic? So lamotrigine is titrated in this very specific way. So there is a drug-drug interaction between either valproate or carbamazepine, which we'll talk about in more detail, but let's assume the patient is not on valproate. In that case, you're going to do 25 milligrams for a couple of weeks, and then you do 50 milligrams a day for a couple of weeks, then you go up to 100 milligrams. Often from that point forward, you want to go higher if the person is still having depressive symptoms. So I've typically had patients 100, 150, 200 milligrams of lamotrigine, not uncommon, even 300 milligrams. In the epilepsy world, they use this 600, 700 milligrams sometimes. You got to warn patients this is not going to work overnight. What we're looking for is an overall improvement over time. So if you tell me that you have sort of 3 episodes of depression a year that last, a couple of months each, if we start showing this and we check in a year, I would love it if you told me, you know what, I only had one period of depression this last year and it only lasted a couple of weeks. One of the ways that you'll find that is by having patients do mood charting every day, just kind of come up with a scale, however you want to do it. 5 is a normal mood, anything below 5 is a negative mood, anything above 5 is a positive mood, but just, maybe they make a little quick note in their phone or on a calendar just to be able to keep track of trends. But that's the kind of trend I would look for that would be a marker of success with this medication. Now, drug-drug interactions, going back to our earlier talks about pharmacokinetics, lamotrigine is processed through gluconeryl transferases. So normally these are going to come through at this pace. If we introduce an inhibitor of the gluconeryl transferases, such as valproate, now remember the lamotrigine is going to be processed at a slower rate. It's inhibiting that enzyme. That's going to cause lamotrigine levels to rise and technically increases the risk of a rash. So if somebody is taking valproate and we want to introduce lamotrigine, we're going to first drop the valproate level by 50%, and then we're going to introduce lamotrigine slowly. So we're going to spread it out. We're going to do 25 every other day for 2 weeks, and then 25 a day, and then 50 a day, and then get up to 100. Okay. Carbamazepine, the opposite problem is true. So now we've got this induction of those gluconeryl transferases. So by the carbamazepine. So now we're going to have to increase the lamotrigine to not chew up that lamotrigine more quickly. So if that's the case, and these other inducers this would apply as well. So phenobarbital, primidone, etc. You're going to double the dose of the lamotrigine as you're initiating it in order to maintain those similar serum levels as if they were not on carbamazepine. If somebody is on lamotrigine already and you want to add valproate to it, you're going to reduce the valproate dose for 50%, and then you're going to go ahead and add valproate. And the reason for that is because that valproate is going to then cause the lamotrigine clearance to slow down, which means that you'll probably get roughly the same serum levels with 50% of the lamotrigine as you did when before they started valproate. And again, anytime you're making changes in here, you're going to want to monitor for a rash. Like I said, every time a new anticonvulsant comes around, we get kind of excited in psychiatry. We hope that it's maybe going to be a mood stabilizer. Here's a list of medications that haven't really panned out for the treatment in bipolar disorder. There are some people that still feel like carbazepine is a useful mood stabilizer. I think the data is kind of mixed on that. But topiramate, gabapentin, pregabalin, really no evidence has been found that they were working for bipolar disorder, despite their kind of initial early enthusiasm, which some clinicians still maintain despite the absence of evidence. Okay, so we're going to go ahead and wrap this part up here, and then in our next section, we'll come back. Thank you.